environment where often we are criminalized as human beings, facing a lot of stigma within the work that we do as individuals. But there is a lot of work that has been done in many countries. In Botswana, for example, Lekhabibo, the organization that I'm leading, was refused registration 3 times. We had to take the government to court, and it took 3 years before we won the court, both at the Higher Court and the Court of Appeal. And 3 transgender men and women took government to court for refusing to change the gender marker. Gender marker is in the ID. You have a birth certificate, an identity card, and a passport to change it to the correct gender marker as per their identity. And recently, in June, we won a case on criminalization of same-sex sexual activities. Of course, the case is under appeal at the moment, and the struggles continue. And all this was done by members of the community themselves, community mobilization, movement building, and such, within the community without any support of government whatsoever. So my panelists here will talk a little bit about the work that they've been doing in their own difficult environment.
Good afternoon. My name is Peter Njane. I come from Kenya. I work in an organization called ISHT-MSM, which is a community-based organization that works with men who have sex with men. We run an exclusively gay MSM clinic. It's one of its kind in Kenya, and it's one of the oldest organizations in the country. I also represent the key population, called the key population, which is comprehensive of male sex workers and female sex workers, men who have sex with men, and IDU, people who use drugs. I represent them in the CCM, coordinating mechanism for Global Fund in the country. First and foremost, being gay in Kenya is criminalized. If you are found, you'll be imprisoned for 14 years. And that aside, that's when you are caught on the act. You can be imprisoned for 14 years. And this is a law that we inherited from the British colony, and which has never been changed. We have tried to challenge it in the court the other day, but the court upheld it. That's aside, that there's a lot of stigma and discrimination in the country being gay. Being an African guy, being gay, there's a lot of stigma that comes within it. So that context makes us hard to work to do anything, because the society stigmatizes you, your family stigmatizes you, the government arrests you. So there's a lot of blackmail, there's a lot of extortion from the police, from the community. Now comes in when you are HIV positive and you are a gay man. That's a double stigma. You get stigma from the community itself and from their society. So our organization came in, it's one of the first organizations that started in 1997. But it started being active in the year 2002, and started having conversation with the government, inclusion of men who have sex with men in the HIV programming. So how we strategized it is, it was really hard to us coming in and having an argument or a conversation about gay or human rights. So we went into health aspect of it, and which we were able to have conversation with the government in the inclusion of men who have sex with men in the National Strategic Plan of HIV, of which we were able to be included there. And even now, what I'm happy about is that the National AIDS Control Council has recognized men who have sex with men as a key population within the HIV context. That has been able to be recognized by the government. We have been able even to have a conversation in the table that whereby in the CCM, we have 2 seats for the key population in the Kenyan context. So that, because before what happened is people were discussing or having conversation about us when we were not there. But now we have a voice, we have been able to capacity build our members that have been able to have that conversation with the government. That aside, we have been able to mentor other organizations in the country to start their organization and give a service to the members. When we started this organization, I started as a volunteer. And we volunteered for like 4-5 years, which has not been easy, all those the stigmas that we have. But currently we have like 30 working staff and 100 volunteers. We call them peer educators. So that means that the country has really emerged one of the organizations in the country.
Kolkata Rista is our organization, and we are working with Kolkata Rista, and I am the founder secretary of Kolkata Rista, and we are working from the last 16 years in Kolkata. We are also working in the 4 states of India: Bihar, Jharkhand, Uttar Pradesh, and West Bengal. Let me tell you one thing first, that we are till now criminalized, criminal after the judgment in the eyes of people. The judgment is only in the court, and the court just decriminalize us and say that you are now free. But we are the more problem after the 377 and after the transgender rights. We have started our journey with health issue. Then slowly and slowly we moved down to the gender issue. It is such a discrimination that all the project is going to them. It is just a Dan type of things, that only 1 or 2 project goes to the CBO. The rest project, which is committed globally, internationally, that it is all goes to the CBOs and NGO, is not yet gone. So that's a big discrimination. And that's a big obstruction in our life, where we will go. Because we know if a non-community people are working with us, then the discrimination level will be more high. We cannot express our identity, we cannot express our problem, we cannot say what we are facing in our daily life. Either we cannot be able to go for HIV testing. So that is what, this is a very big example I shared you.
I've been part of the women's health movement in the 80s, then been part of the queer rights movement from the 90s. And I'm part of a collective in Bombay, which is Labia, a queer feminist LBT collective. And so I speak from the location of being a queer feminist. I would not really speak as much. I see the relevance of speaking of the identities that we are here, of speaking of the exclusions, of speaking of where all we needed to be there, but we are not there. But I'm going to use this platform to actually throw the question back. As somebody who's worked in women's health for a long time, as my understanding moved from being a feminist to being a queer feminist, and other kinds of adjectives started getting added to my feminisms, whether it is trans, queer, Dalit, there are ways in which one is understanding people, the ways in which one is understanding who these women are. When we say women's health, then who are the women that we are talking about? And I think unless we speak of that, there is no way that we can speak of the lesbian question. So, because we're going to concentrate on gender and sexuality, I'm going to take that slice and speak from there. That when we are going to a healthcare system, the healthcare system and everybody else in society, including many of us here, think of sexuality in the context of marriage. So there is a compulsoriness, I think this was mentioned in the earlier session on SRHR, that there's a compulsoriness to marriage to the extent that if you're married, then you have to be sexually active. And I stress the word have to be, because I need not be. And if you're not married, then you're not sexually active. That's one equation. The second is, what do we understand by sexually active? It's penovaginal sex. So it's an assumption that if a married woman goes to a clinic, she is having penovaginal sex regularly. Is an assumption with which the healthcare worker looks at that woman. If she is not having sex, she is going to find it difficult to say so. If she's not having penovaginal sex and is having sex which might be criminalized under 377, which could have been criminalized, she's definitely not going to say that. So actually the problem is for everyone. The problem is not only for us. Yeah. So when a lesbian woman goes, obviously, she's hiding many of these facts. She's encountering a system which is understanding sexuality in a very normative manner. And maybe we should also think whether when we speak of sexuality, are we doing the same? The other question that I want to raise, and which is linked to what Santosh was speaking about, is that we also have an understanding of gender. Which is the binary gender? Yes, there are two genders. Nowadays, we become aware of many others, but deep down in our heads, gender is two. Not only is it two, it is connected to the body that you have. If you have a vagina, you are a woman. If you have a penis, you are a man. All the women's health that we're talking about is assuming that this body has a vagina. And this body does not have a penis. This body does not have the kinds of hormones that we think bodies with penises have. Yeah? We've not, I mean, there are people around us all the time who are living with bodies with variations. Many of us might have come across them, but they are the exceptions. We don't talk in terms of exceptions. We talk in terms of, we complain about the medical establishment talking in terms of the normative. We do the same. So the woman that we talk about is the woman who, when born, had a vagina, was called a woman, continues to call herself a woman, preferably is married, and preferably is doing penovaginal sex. So as far as gender and sexuality goes, this is what has been our frame for a long time. And by our, I mean many of us here. So a lot of our women's health campaigns have understood women in that manner. So when we speak here, then it is like, oh, these others. And I refuse to speak as the other. And many of us would refuse to do that. Because the question is about what structures have we constructed or reinforced. Society has structures which we are reinforcing, and probably the need for any kind of, if I may use the words of accountability, the need for accountability is from each one of us as well. There was in the earlier session, somebody spoke of, in the South Asia region discussion, of the peculiarity of Dalit women, peculiarities of sex workers, peculiarities, and I think that there's no point in just seeing them as peculiarities. There is need to look at what is the normative that is getting constructed and how is our work reinforcing that normative, or better still, how is our work helping to dismantle that normative?
What I'm going to talk about is sort of taking from what Chanika says. I'm actually not going to go into common mental health difficulties that queer people have because of the way the society is structured. I'm actually going to look at mental health systems, and so just to quickly, I'm actually going to look at two systems. I'm going to say something about law and medicine. And the reason to do that, again, law has been highlighted in a big way by two speakers at least before me. The primary reason for that is that we know that globally there has been a very close link between criminalization and pathologization. And I just want to point out some of that specifically in the Indian context. So In India, we've had this very strange history vis-a-vis pathologization around, how have mental health professionals looked at non-normative genders and sexuality. We know that the American Psychiatric Association in the 70s, early 70s, 73, said that homosexuality is not mental illness anymore. What happened in India was that our professionals continued to say that homosexuality was illness. They continued to treat it as illness. So conversion treatments, ways to change sexual orientation continued, not just in clandestine ways, which continue even today, but in extremely formal ways, such that even formal journals, medical journals that came out of India between 73 of APA decision till as late as late 2010s, you had journals which document this idea of curing homosexuals. The reason I'm saying this is to say that what was the link with criminalization? So suddenly in 2009, you have the Delhi High Court, which said that, there's this famous judgment about reading down Section 377. And then slowly within the mental health system, you see some murmurs about some support and to sort of start looking at what's happening in practice. Finally, in 2012, we have an editorial of the Indian Psychiatric Society saying that homosexuality is normal human variant, human sexuality variant, etc. Then comes 2013 when the Supreme Court again criminalizes homosexuality. 2014, the Indian Psychiatric Society president goes on record saying that this is non-reproductive sexuality and therefore it's abnormal. You again have a letter to the editor in the same journal, which is the official journal of the Indian Psychiatric Society, saying that since this doesn't lead to procreation, this is abnormal sexuality. So this is just to sort of point at this very interesting link between, and then of course 2018, 6th September, a day before the Supreme Court judgment comes out, the Indian Psychiatric Society made a statement again saying that we think homosexuality is normal. Of course, the other associations like psychology, social work, counseling, etc. have not said anything, and nobody has said anything about conversion treatment. So nobody has come out and said that if homosexuality is neither a crime nor an abnormality, why are we trying to change it? Similarly, one other thing that happens is that with law, some things change, and yet we know that how the medical system works, it may not change in the sense that it tends to change, accommodate, include, sometimes co-opt. And so we do see one of the things that the Indian Psychiatric Society did was that they started what is called as the LGBT task force, within which one would think is a welcome thing to start talking finally about mental health issues of queer people. What has ended up happening, of course, is this task force is largely led by cishet people. There is some representation of gay men, and what is being talked about is gay men's mental health issues, and that is being passed off as LGBT task force. This again in the context of accountability, which is being raised here in very many ways. So LGBT task force in India, for example, which is now a official part of the Indian Psychiatric Society, does not say a thing about, we know that there is a transgender rights bill that was passed in Lok Sabha and is waiting to be passed in Rajya Sabha, and it says that who is a real transgender person is going to be decided through medical screening, but the LGBT task force has nothing to say about that. Yeah, so this is just to point out how these things work. One other example of, before I sort of stop for now, is to also point to the fact that we had the Supreme Court judgment in September 18. November 18, the MCI, the Medical Council of India, comes up with a revised curriculum for undergrad education, medical education in the country. We all may have known about, much has been said about that curriculum. So this curriculum has come out after 21 years and is touted as something that is positive. It's looking at competencies and all of those kinds of issues. The forensic medicine and psychiatry curriculum continues to refer to lesbianism, buccal coitus, what is the other thing? There is sodomy, incest, etc., as various forms of sexual deviations and offenses. In fact, there's interesting work done by someone called Dr. Tirthankar Guha Thakurta from Kolkata, who has looked at medical textbooks, and he's sort of looked at how have queer people been represented in medical textbooks, and he refers to this textbook of forensic medicine and toxicology by somebody called K.S. Narayana Reddy, 21st edition, which makes this interesting. So this is forensic medicine, right? So close again to looking at medico-legal sort of issues. The textbook will tell you that there is something called as natural sexual offenses and unnatural sexual offenses. So something called as natural sexual offense, which is rape, incest, adultery, and the unnatural sexual offense, which is of course sodomy and tribadism and so on and so forth. So yeah, so I just wanted to point out 2 or 3 of these things before I sort of stop. I also want to say that parallelly with in some ways, the depathologization of homosexuality, and we are not still saying something, not clearly saying something about gender identity disorder and gender dysphoria. In India, at least, the mental health professionals have not come out and said clearly what their stance there is. But parallelly, what is happening is that at least in cities, and particularly when we celebrated the first anniversary of 377, suddenly you have this proliferation of lots of people saying that they're doing mental health friendly work. So you have, in fact, there's a exodus of lists being created in various parts of the country saying who are the mental health friendly professionals in your region. I just want us to think a little bit again about what do we mean by this, because for the longest time we have been treated as abnormal in the clinic. So mental health friendly doesn't mean that this doctor does not treat homosexuality and does not cure it. Does it mean that they have finally come to accept that some of their paying patients are going to be queer? So they have learned to be queer tolerant. Does it mean that they have finally accepted that there is something called as this gender sexual diversity and therefore they become queer accepting? But this is still very far away. The conversation is very far away, both in training and practice, from what is queer informed. Do we have a conception of queer trans informed competent practice? We are very, very far away from talking about queer affirmative practice, which is essentially a political sort of idea. And at some point, if there is time, I would talk about then what is happening and where is the hope. And so, yeah.
This is Abul Barkat from Bangladesh. I'm mentioning my name since my name is absent in program book, even in name card also. However, I actually want to talk the issue about the advocacy with government. The issue is a recognition gender diverse population in Bangladesh perspective actually. Firstly, I want to say some background on some initiatives from Bangladesh government. Recently, Bangladesh government have taken some initiative for the gender diverse population. Like in 2013, the government cabinet decided to recognize the Hijra community and reflect their presence in national identification documents and census also, so that they can give their rights and other services also. And second one is in 2013, the Ministry of Social Welfare declared a gazette like 2013, Ministry of Social Welfare introduced some livelihood schemes for the gender diverse population so that they can get financial support from government in under safety net program. In 2014, the Ministry of Social Welfare's publication of a gazette notification as Hijra gender. In our Bangladesh, Bengali, Hijra lingo. The recognition is Hijra lingo. But there was no any definition who is the Hijra people, how we identify the people. And in 2018, an important step to change the law was taken in the amendment to the Voter List Act 2009, where the Hijra people get the voting rights and included in the voter list. So that was another steps from the government. But to getting the rights, there is a big difference based on the Gazette notification that I already mentioned. The reality is, the Gazette means only the Hijra community, leaving out other communities and individuals who have non-normative gender and sexual expressions but do not belong to the Hijra community culture. This reflection a prevailing confusion about the idea of gender, as the Hijra community is only one of many diverse communities, you know. So the first one is identity documents. Like if I give some example, based on the Gazette notification from Social Welfare Department of Bangladesh government, like 3 example, after the circulation, the national identity card includes Hijra category, national ID card. And in passport, they includes a category of other for the Hijra community. One is Hijra, another is other. And third one, a government bank, government state-run banks, they included a category of third gender. Like how they get their services, since different forms identified them differently. So this is a big challenge to get their services from government initiatives. Another was physical examination. In the absence of any guidance of the nature of Hijra community and Hijra culture, relevant authorities often resort to carrying out physical examination to verify whether a person is an authentic Hijra. This happened in 2015, when 10 members of the Hijra community by the Ministry of Health were declared to be fake Hijras because of their physical organ. When the physically tested to identify them as Hijra, they thought this is fake Hijra. He is not actual Hijra. So, though the government have some initiative identified as Hijra Lingo, this is also an initiative, but currently there are many consequences arises because some challenges also. So, right here, right now, Bangladesh platform, it's a global platform, runs in Bangladesh with 11 organizations, that is Bandhu Social Welfare Society is hosted this platform. We are working on this issue actually. Our platform's main points of advocacy towards ensuring recognition of gender diverse identities has been to seek clarification of the Hijra recognition by the government and to expand the recognition to cover all diverse gender identities, including transgender also. So we are working with this issue so that all community peoples, including Hijra, trans men and women, all covers this issue actually. The platform introduces advocacy with different stakeholders like government, public, private sectors, journalists, government officials, and we try to sensitize them. We try to understand them that this is not the same issue like Hijra, not cover all the communities. Our recent platform has conducted research also so that we can identify the areas where we need to be changed for relevant laws and policies, the forms and formats where we need to address this issue so that the Hijra community people get their rights, get the services from the government. And undertook as advocacy as part of the research initiatives, has also mapped existing stakeholders in Bangladesh working for the rights of Hijra and gender diverse identities. The platform also worked with faith leaders because faith leaders are actually main barrier to implement this circulation or changing the laws, because they are the first they talk against this issue because of the religious law. So the platform has also worked with faith leaders across the country. A part of this advocacy to sensitize faith leaders on the concept of gender diversity and try to remove any discrimination towards gender diverse individuals on the ground of religious laws. So we also have developed a concept note based on 4 religious books, where how the religious books told about the gender diverse population, so that these briefings can help us to motivate another religious peoples, even the general people.
Peter, in Kenya, I know of a large constituency of LGBT community who are asylum seekers and cannot enjoy some of the healthcare services that are offered, being that they are asylum seekers, and some of them might not have the necessary documents in the country. Is it possible for us to link them to your clinic for them to benefit from your programs?
The first question came from my brother about people who seek asylum, and especially the Ugandans. We have a lot of Ugandans who have migrated to Kenya to seek asylum. And yes, we are giving them services. They can come get services. Our services are free of charge. And we don't even ask for their IDs. The problem we have with the refugees, asylum, especially the Ugandans, is the high expectations they come with. For example, and you know that, for example, our facility is HIV oriented only, service delivery. When these refugees come, they ask more than what we can offer. Even what we Kenyans, we don't have. That's what the problem we have. I've had a lot of meetings with them, and I tell them, we give 1, 2, 3 services. So in that size, if you are part of that, if you need that 1 to 3 services, you are our brothers. They are coming have sex with us. So if HIV is to spread, we're all gonna all have it. So if they have that, ARVs are giving the ARVs, the PrEP, but the problem we are having, especially with the Ugandans, is the high expectation. They want us to pay rent, they want us to do this. So we are partnering with Hires to give that information on health component only.
LGBT rights is not just about access to a private space, a private home, a private room, but also privacy within public spaces. So I think, just in terms of police violation and street-based sex workers who are working on the streets, if Santosh, you have anything to say in terms of any change that has happened with 377 getting decriminalized now?
We are facing more discrimination. Hey, guys, why you are here? You got the IPC 377 free and all. Go, why you're standing in road? Why you're standing in street? We are waiting for a customer. We are waiting for a client. We need money. So, no, this is not a place for you. And no privacy is there. Even in the hospital, when we are going to take the services on counseling, one of my friends, sorry, I'm changing the name, Rani. She's having another name. And she went to her partner. And her partner was pregnant. And she says that, तुमने इस ट्रांसजेंडर से इस हिजड़े के साथ शादी की, तुम्हें और कोई मर्द नहीं मिला. So that's very important. And it's very funny. I'm so sorry. I'm very hardcore feminist. But I'm very shocked some of our feminist friends say, don't you think जब transgender किसी औरत से शादी करते तो it's a discrimination for that, वो उस औरत के लिए क्या मतलब है? This is love. This is the expression. इस पे भी आप पाबंदी लगा दोगे हम किसके साथ सोएं? And जब हमारी मित्र बातें कर रही थी, and we always talk very openly. LGBT के लोग बहुत खुल के बात करते हैं. And we talk vagina, penis, and everything. And they say, oh God, they're so dirty people. बड़े गंदे लोग हैं. बहुत खुल के बात करते हैं. Amma yaar, you people asking us to open. And you're asking us to shut your mouth. Shut up. Don't open your mouth. So where we are standing, that's the most important. And no privacy.